So without further delay, I'd like to call on and welcome our first presenter, Brendan Walsh from DSRI, to present on the effects of new residential developments on local healthcare demand and workforce.
Thank you very much, Derek, and thank you very much to the organisers for the opportunity to present today. I'm going to discuss a new model we have developed at DSRI to provide an evidence base on healthcare supply and healthcare demand arising from new housing developments. And this is work which is undertaken with my colleague here, Harry Humes, who's in the audience, who did a huge amount of the heavy lifting on the technical aspects of this work. Firstly, I want to acknowledge the funder, the Department of Housing, Local Government and Heritage. And from the outset, I want to say that this has not yet been peer reviewed. It hasn't been published, so what I'm going to show you today is still at an earlier stage, but we do plan on publishing a report on this work early in the new year. So just to think about the need for this type of work, there is clearly a need to better integrate housing and healthcare planning within this country. And I think we now have an environment which is much more conducive to that integration occurring. From a healthcare demand perspective, we have much greater grasp on the key drivers of healthcare demand and where demand might be going in the upcoming years. So at DSRI, we've developed a projection model called Hippocrates, and we've now published a number of different outputs from this model, projecting health and social care demand, supply, expenditure and workforce at a national, but also more increasingly at a regional level. And we know from these outputs and also similar international studies that we can actually identify quite well the key drivers of healthcare demand, which makes it, at least in the medium term, easier to allocate resources in terms of where healthcare demand might be going and make better informed decisions about workforce, capacity, infrastructure, etc. From a population-based point of view as well, the Department of Health are currently establishing a new population-based resource allocation mechanism. And this is going to be based around the new HSE health region. So this is a key recommendation of Sláinte Care. So in the past, it was quite difficult to kind of match healthcare supply to population differences in population differences, especially at a regional level. But while this may take a bit of time to be established and to be embedded, it will provide a much better basis for us to make systematic and transparent decisions around resource allocation and funding decisions more generally. And we know that there's quite a lot of changes that will be needed because of our demographic circumstances in terms of workforce, infrastructure, capacity, and also model of care changes. And a lot of these changes will require a lot of coordination and integration with a lot of local and national planners outside of the health arena. And just thinking about the large structural changes which have happened in Denmark this morning, the huge amount of actors who were involved in that. Then from a housing perspective, we clearly have a lack of adequate and appropriate affordable housing in the country at the moment, but we do appear to be at a stage now, or at least at the beginning of a phase, of developing based upon strategic planning and building houses more along the lines of regional and residential developments in a suburban and urban area, and moving away from the kind of one-off builds which were a feature of housing supply in the past. A lot of these residential developments then will be quite different, so they can range from small housing estates on the outskirts of towns or cities to kind of larger developments like we have in South Dublin and Cherrywood, or new towns that have been built in West Dublin like Adamstown. It's the first new town we've built in this country since the 1960s when Shannon was built. And a lot of these developments will have certain characteristics, but all of them will have implications in terms of healthcare demand, not just for those individuals who might move to the region, but also for existing locals. And as I said, we've been reasonably poor in terms of matching healthcare supply to population change. We've shown in previous work that those regions that experienced the fastest growth in population in recent decades now consistently have the lowest supply of healthcare. And just thinking, I suppose, in a more overarching sense about housing and healthcare, like housing and the local environment are key social determinants of health. So better integrating these areas will allow for healthier communities, better population health. And there are a number of excellent examples now from a range of different countries in Europe and elsewhere of this integration taking place at a national level, at a regional level, and more increasingly at a sub-regional level. And just in terms of the general public as well, health and housing are consistently put at the top of their agenda. So this graph here, I think, epitomises this. It comes from a survey which was published in the Irish Times prior to the last general election, where individuals are asked about those issues would it influence the party or the candidate that they may vote for. And housing and health are clearly out in front here. And while we still have bigger issues now in terms of cost of living, the public and the political discourse are still dominated by the issues we have in terms of housing and healthcare. So that's to give you kind of a quick whistle-top tour to the context of this work. And in what will be hopefully the first phase of a multi-phase project, we have three key objectives. The first was to better understand the relationships between housing and health more generally, And we published some work on this, which was published as an ESRI document in June. The second then is to develop a new model or architecture which will provide an evidence base for health and local planners with regards to housing demand or healthcare demand and healthcare supply arising from local developments. And then in a more overarching sense, just to provide better evidence on how to integrate housing and healthcare planning. For the rest of my presentation, I'm going to focus on the housing and healthcare planning model here. And just to kind of bring you into the construction of the model in the first place, many of you might have come across microsimulation or microsimulation studies, and these track individuals. We use a slightly different architecture here. So the model is based on a cell-based or macro simulation architecture where we combine the behaviors of groups of individuals or cells. And we've broken the model into 3 specific stages. The first, we estimate healthcare utilization rates or healthcare activity rates at a national level for a range of different healthcare services. And then we disaggregate that activity by the key drivers of healthcare. So it's age, sex, medical card, and GP visit card status in this country. And we use a number of different data sets for this. If you were to think of the information that would be included in a cell, it could be the number of GP visits on an annual basis for a 35-year-old female who does not have a medical card, and then we aggregate that all up to a development level. In terms of a profile and our developments then, they can differ across a number of different attributes, in terms of size, for instance. But importantly, they will differ in terms of tenure composition. And tenure, as I'm going to show you in a few slides' time, is really important when we want to think about healthcare in this sense. So to some extent, we've built our developments up from tenure groups, and to do this, we've estimated what a typical household in each tenure group looks like in terms of size, but also the age, sex, medical card status of each of the household members. And we focus on 3 specific tenure groups here. So the first are homeowners who might own their home outright or via mortgage, private renters, and then supported renters. So these might be people who are receiving direct or indirect provisions in terms of social housing supports. And then finally, and probably the most difficult because of data limitations, is estimating a healthcare supply-demand ratio. So for this work, we do not include things like unmet need or waiting list or appropriate staffing levels. We essentially use current levels of service. So in the areas of, say, hospital care, we know the total number of inpatients who might be admitted into a hospital in a given year, we know their average length of stay, and we know the types of beds and the amount of beds used to provide that care. For other services, we've leveraged the information which has been published. So for example, when it comes to GP care and practice nurse care, we rely on a piece of work by Claire Collins and others in the Irish College of General Practitioners, who have a big survey of general practices at the beginning of 2020, where they were able to estimate the annual number of GP visits per whole-time equivalent GP and the annual number of practice nurse visits per whole-time equivalent practice nurse. And then we grossed them up to a national level for this work. So just a very quick kind of diagrammatic representation of the model itself. We use data to inform our development profile, our activity or utilization profile. We bring both of these together to give you kind of total healthcare demand in a new development. And then we include some information on workforce or supply to demand ratios to this. This will be, and what I'm presenting to you today is the first kind of outputs from the model itself. So we're only going to cover and focus on a small number of healthcare services. Some of this is due to data limitations, especially across certain primary and community care services. So we're going to focus on primary care or general practice here, and also public acute hospital care. Like obviously these are going to be key parts of the healthcare system, but they also have quite differing demand profiles. And as I'll show you when you apply that to your developments, then you get quite different demand profiles at the development level. We also do not, in this work, try to focus on specific development examples. So I'm not going to show you results on the number of GPs Adamstown or Cherrywood or some small estate outside of Athlone may need in the coming years, because we just don't have that level of information yet. But I think once we do, we'll be able to expand the model to look at those specific examples. So instead, we take 3 hypothetical, or what we call benchmark development examples. The first one here relates to the Housing for All plan, which is the government's policy for housing. And there are a number of targets within this plan, but one of which relates to new houses being split into about 30% supported housing or affordable housing, 20% for private rental sector, and then 50% for homeowners. And then our other 2 benchmarks here, our B and our Cs, essentially just vary the levels of public and private housing within these developments, kind of using the Housing for All development as our kind of key benchmark here. Then in just the next few slides, I'm going to show you the type of information or inputs we include in the model itself. A lot of this is based upon the level of information and data that we have. But from the outset, it was quite clear that we wanted to build our model from the tenure type up. And I think this is going to be clear from the next few slides. So if you look at the age structure of our different tenure types here, so from supported renters, private renters, and homeowners, they're very different. So on the right-hand side in green here, you can see that homeowners generally skew older, while supported and private renters skew quite a bit younger. And if you think of the impact age has on healthcare demand, this can really impact demand when you estimate it at a development level. Then in terms of household size, so in this regard, it's the number of people who live in a specific household. Again, it varies across different tenure types. The largest average household size are for homeowners. The smallest are for private renters. Some of this is due to many private renters living in 1 or 2 bedroom apartments. Many homeowners will live in terraced, detached or semi-detached houses. But again, taking the household size into account became important as well. But the biggest difference, if you can see it here, the biggest difference across tenure group relates to medical card coverage. What this graph shows you is the percentage of individuals in each tenure group who hold a medical card. And I'm showing you a longer time span here, all the way back to 2007, because there has been some reductions in medical card coverage in recent years. But if you concentrate on the right-hand side of the screen in 2021, which is the data we include in our model, about 75% of supported renters hold a medical card, while less than 25% of private renters or homeowners hold a medical card. Now, there's obviously reasons for this. So socioeconomic circumstances will differ across tenure groups. Deprivation will differ. We've shown in our previous work that in the supported rental group, their rates of chronic illness are over twice that at every age group compared to the homeowner group. So there's a lot going on here. And also when you think about direct or indirect provisions for social housing and medical cards, they're also both arms of the social welfare system. So you would expect quite a bit of correlation between these different areas. So they're kind of our key socio-demographic parameters we include at the tenure level in our model. And next I'm going to bring you through the kind of healthcare utilization or activity rate profiles we include in our model. So there might be a lot going on here, but none of it will surprise you. But essentially, GP demand increases with age. Males tend to have lower demand for GP care, especially amongst the younger working age group, while medical card holders and GP visit card holders also have higher demand for health care across all of or GP care across all of the age groups. We see a slightly different profile then when it comes to inpatient care in public acute hospitals. This includes both elective and emergency care, just to make it simpler for this presentation. So there's less of a variation between males and females, but demand increases consistently and considerably across the age distribution, while medical card holders also tend to have higher demand for care for a number of different reasons. So what I've after shown you in the last few slides are essentially the type of information we include across our profiles or within our cells in our model. And in my next few slides then, I'm going to show you how we aggregate these up into benchmark developments. As I said, I'm not going to focus on any specific development, and I'm going to present my results as a kind of generic 1,000 unit or 1,000 home benchmark developments. So first, looking at GP care, if you're to concentrate on column A here, so that's the housing for all development, across 1,000 units, we estimate a total population of just over 2,500 people. That's our kind of tenure breakdown across each tenure group. And we estimate total demand within this development for GP care of just under 11,000 visits per annum. So that's bringing together our activity rates estimated at the national level with our development profile applied to that. And using the work from the ICGP, this equates to approximately 1.5 whole-time equivalent GPs to provide that care. And in other work, we can put bounds around these as well. These are just point estimates at the moment. You can see then in column B, demand for GP care increases in the public housing development. And as I said at the beginning, we've built our model in a macro simulation way. So we've built up from cells into a specific development. That means we can also decompose these results into each of the parameters as well. So looking at the differences between column A and column B here, you can see that supported renters are a large proportion of the public housing development here. They tend to have much higher rates of medical cards and GP visit cards, and that seems to be driving the difference in demand between the housing for all development and the public housing development. And then secondly, looking at inpatient care, you see something slightly different. Again, if you were to focus on the housing for all development, we estimate total demand expressed as bed days, or how long an individual might spend in hospital, of just under 1,800 inpatient bed days per year, which is the equivalent of just under 5 inpatient beds in a public hospital, assuming that that bed is staffed 365 days a year and fully open during all that period. Demand is actually smaller in the public housing development here. So as I showed you earlier, age is a key driver of inpatient care. The public housing developments skew slightly younger than the housing for all developments because supported renters are slightly younger, so they tend to have slightly lower demand for inpatient care here. So those are the type of results that we've produced from the models so far, and trying to apply everything in some type of benchmark development based upon current service levels. But the model, as I said, is quite flexible. Where we have information and data, we can add parameters to it, hopefully not to overcomplicate things or oversaturate things. We can change our activity rates, and we can also change the development profiles themselves, which means to some degree we can simulate changes or healthcare policy changes. So one of the changes that we have simulated, and going back to some of Marisha's point earlier, is from Sláintecare, so the introduction of universal primary care within this country. So there has been quite a number of studies published in recent years, including by my colleagues at the ESRI, estimating what the increase in GP demand will be if somebody was to gain free GP care. And this work has been done for children and adults alike. And you are seeing quite large increases in demand. If we were to apply that distribution to our baseline kind of current policy, you can see we would have quite large increases in GP visits, especially in the older children and in the working age population, who tend to have lower rates of free GP care currently. And then applying that to our generic 1,000 unit housing for all development. On the right hand side here, you can see in column B, compared to their current policy, we would expect about a 20% increase in demand and subsequently a 20% increase in GPs required to provide that care. Now, we understand this is a little bit of a straw man argument. It's a simulation based on what could happen. It assumes that GPs will be able to provide the same levels of service after universal primary care was introduced than they do currently. That's not going to be the case unless we increase capacity, obviously. But because the model uses a supply-demand metric, we can switch things around a little bit, where the model could be used to look at the additional workforce that would be required if we were to introduce some type of new policy, such as universal universal primary care. So just to finish up, I think it's quite clear, and I'm not the only one who's kind of been talking about this for the last number of years, is that much greater integration between healthcare and housing planning, or planning more generally, is required. They've been able to do it quite well in other countries. We seem to be lagging quite a bit behind where some of our nearest neighbours are. I think what this model and some of the evidence I've showed you today is that there is scope to develop guidance on healthcare demand and supply requirements using the information that we currently have. But as we gather more information in coming years, to some degree, based upon the new health information bill, we should be able to provide more focused guidance. We should be able to target specific areas of the country. So, for example, in West Dublin, there's now proposals to build a 40,000 home or 40,000 unit new development called City Edge. I think this type of model has the capabilities to inform what type of infrastructure, workforce, etc. will be required in that area. As we also gather more information on current levels of capacity and supply in an area, we can also make better decisions about smaller estates or smaller developments as well. Just want to say that this is the first results from it. The model is still very much in its infancy. We call this maybe HHP 1.0, but we have identified a number of future expansions or iterations that could be included in the model. So, for example, looking at a wider range of health and social care services, which will become much more important in the community. Projecting future demand and supply. So we know from the work in Hippocrates, what the population requires now will differ from what it needs in the future as it grows and ages and has different types of healthcare needs. Local areas also move in a certain demographic direction. Infrastructure, not just in terms of primary care, but also maybe e-health and better integration and coordination across different multidisciplinary teams. And then moving on to other areas outside of healthcare, this type of approach has been used in other countries to look at childcare, education, etc. But again, it's all data dependent. So thank you very much.